Hello, I'm Dr. Steve Karstensen, Editor-in-Chief of Dental Sleep Practice Magazine, a MedMark publication. Welcome to a live presentation and Q&A with Dr. Payam Atai. In our webinar today, we'll be discussing the relationship between airway, malocclusion, and sleep disorders. This webinar will provide guidance in managing and overcoming hurdles for complex patients who present with multiple medical and dental conditions. We're going to talk about OSA and upper airway resistance syndrome, minor tooth movements using clear aligners, technology, and partners with turnkey solutions. Before we get started, I'd like to invite viewers to use the question box in your control panel to ask any questions. Your questions will be answered at the end of the presentation. So I'm pleased to introduce our guest for today, Dr. Payam Atai. Dr. Atai is an award-winning graduate of Tufts Dental School who has treated more than 1,000 patients with clear aligners and sleep oral appliances as mono and combo therapies at his private practice in Laguna Hills, California. Dr. Atai has been an Invisalign faculty member for more than 10 years and recently was awarded the North American Educator of the Year for 2016. As an author, Dr. Atai has been published in national and international peer-reviewed publications, as well as mainstream press, television, and Dental Sleep Practice magazine. Over the years, Dr. Atai has presented lectures to thousands of his peers, sharing the results of his research and his innovative practice growth techniques. Dr. Atai has developed and continues to develop solutions to improve and simplify how dentistry is delivered to patients. Currently, he serves on multiple company boards and is a recognized key opinion leader. I'm pleased to welcome Dr. Payam Atai.
Wow, thank you. I can't thank you enough for this opportunity, and not only kind of having doctors who, as you can see in our scrubs and right after, and I know some of you are on East Coast and late for you, but I really appreciate the time that we're going to spend in discussing a little bit of what I've become a lot more passionate about in the past, I can say 10 to 12 years, understanding what is the role of dentists, and then having that facility of your practice treating patients. And I got to tell you, doctors, it's an honor. Over 200 of you online waiting to hear about this. So again, I thank you very much. And I'll just jump right into it. For those of you who know me, who've seen me, and a few years back, we saw and saw my family grow, and they're toddlers, and now my family's growing. But you might have seen me on the cover of DSP, and you saw me talk about a little bit about appliance and the importance of sleep testing, and what it is that we have to start looking as a general practitioner, and talking about the entire system and the ecosystem of what happens in our practice every day. Understanding that it's not just crowns or fillings that we're actually treating. These patients, some of them come in with problems that are systemic. And the oral health that we see in the oral gateway, and really, and I tell my wife every day, honey, I'm going to work, I'm going to save some lives. And that's really what we're talking about. And understanding that a few years back, my knowledge as we practice dentistry, as we grow into a little bit of time in understanding concepts, and it took me a few years, and I'm still learning, of patients and malocclusion, treating airway, sleep disorders. The medical component and the dental piece that goes together is important. So yes, a few years back, I talked about appliances, talked about the importance of having patients be screened, having patients in our office understand that it's not about snoring, it's not about you just being tired or fatigued, but rather there's a bigger picture. And it took me a little bit of time, at least 2 more years, to understand we're missing a little bit of the medical component. I pick up the phone, talk to the physician may or may not like what I have to say. And sometimes they discount the fact that I'm just a dentist. What is a dentist talking to my patient about? Well, my patient as well. And bridging that medical gap is my agenda today. Understanding and focusing on how every day when these patients come into our practice, we're managing and understanding that the effects of sleep apnea is the entire body. It requires a medical expertise. Just talking about the brain, the depression and high blood pressure, all of these have a medical component that we see. We take a medical history. My patient comes in, I talk to them about, give me an update of your medical history. Any cardiovascular? Are you taking aspirin? And some of these questions may be that we're about to give a lidocaine or we're about to give some sort of anesthesia, but do we look at the deeper effects? Do we look at the fact that there are expertise in the oral cavity that may need that jaw, that bite, the wear, the oral facilities that we see are all connected to that medical side. So definitely there is a connection, as we know. No kidding, Dr. Ty, I know this. Why are you wasting my time? Well, we have to understand that we have to learn to diagnose and treat and manage patients effectively. The word effectively is the highlight here. Because what does that mean? So first of all, just last week, the ADA put their position of a statement talking about the role of dentists in treating sleep-related breathing disorders. And dentists should maintain regular communication with the patient's physician. Maintain. Now, doctors, when I say maintain, it doesn't mean you send a fax and say, hey, I'm about to deliver an oral appliance. We're talking about follow-up. That patient is your patient as long as they're walking into your practice, a lifetime. My patients in the past 20 years, they haven't left me. I've relocated practices. These patients are following, and we have to follow them. Therefore, the medical component and talking to the physician is important. Now, the follow-up, the testing, the confirmation of efficacy, all of those are a role that the ADA has now given a stance. And this is a big deal. This is just a week into it, and now they're defining our role as dentists and what we're allowed to do. And we're progressing into a more advanced, I like to talk about the word that we always hear, airway. What does that mean? What's the airway? Well, we know that I breathe through my nose, I exhale through my mouth. Wonderful. What comes out of my mouth could be halitosis, or it could be some other byproducts that I'm not necessarily getting. So what's airway? What is a conversation that I have to have with my patients as a general practitioner? Now, some of you doctors, I know this inside and out, but understand our team members, our hygienists, our front office, they have to understand that the upper respiratory tract and the lower respiratory tract is considered the entire airway. From nasal, pharynx, larynx, as well as the trachea, bronchial, and lungs are all part of the airway system. Now, specifically, we deal more in the upper airway rather than the lower. Specifically, we deal with more the oral pharynx, and we talk about these patients who come to our practice. Our patients need to understand that we're there, and our team is there, in getting what we talk about specifically the upper respiratory system. That is our focus. As dentists and dental practitioners, when we start to look at the frontal sinus, all the way down to the mandibular and even down below the epiglottis area, those are all within our realm. And when it's neck up, as some of you have already heard me in my lecture, that's our department. So the oral cavity is not just related to the soft and hard tissue. We have to discuss the nasal all the way down to the respiratory and the upper respiratory system. So our agenda is trying to talk about a little bit more in the cranial-facial complex. Okay, so what does that mean? Well, when I look at a patient, I take a look at the cranial-facial complex as I talk about the hard tissue, the cranium, right? Which is consistent of the cranial vault, the cranial base. We start look at some of these face, mid-face, nasal maxillary, and the mandible. These two structures, the cranium and the face, are involved in what I like to talk about the complex, and then now the cervical spine. I myself, some of you may know, 2 years ago, had a little bit of an accident. I tried to go surfing at age 45. Thought I could do it. Guess what? I came head down right on the sand, and guess what? My C1 and C2 has been in pain ever since. Okay, what does that mean? Well, that's 50% of what we're looking at. The other 50% is right down here. This is where the actual medical part comes in, that we're not just treating teeth. We get that. We're not just treating TMD. We get that. What are we treating? Well, first, before talking about treatment, let's understand what is our department. So when we start to look at the cervical spine as the other 50%, we start to talk about how this is affected in the way the patient's chewing, eating, and wearing, and malocclusion comes and plays a role. So what we see in our practice every day, what we start to talk about to our patients is what? Well, patient came in, they have lower crowding somewhere on the anteriors. Okay, what does that happen? That's mesial drift. Doctor, this is what happens as you get older and the teeth start to come forward. I get that. I believe that. I read about it. But what happens as the teeth, some of them progressively start to wear? What happens as the patient, we see these patients who are now having teeth that are completely worn down and bruxing. So, my good friend, I know that Dr. Simmons has done a lot of studies in talking about nocturnal bruxism and relation to sleep apnea. Talking about that airway protection. Again, airway, upper respiratory, lower respiratory, and what goes in and coming out, the upper respiratory being our department. So why are we talking more about what's the missing link? Well, we'll get to this. I want to show you a little bit more and dive a little deeper in how I explain to my patients as to what we're looking at. What are we really looking at here, patient? Are we looking at getting a neck guard? Are we looking at talking about you wearing down your teeth and maybe you should, I don't know, change your plastic piece in your mouth? Maybe we need to talk to our team about it. That's not the case. The educational piece that I've missed in dental school was specifically not about that gold crown that I delivered on my uncle a few years back. This is about 20 plus years ago, actually 25 years ago. My uncle, that gold crown you see, was delivered on the lower arch by me. That's the last time I saw him because he moved to Canada. And the next time I saw him was in 2012. The gold crown was still holding up nice. That is not the way his teeth looked. Where bruxed, and they couldn't figure out why he's having some issues, some diabetic, cardiovascular, and yes, most importantly, he's going towards the Alzheimer's realm. So what happened here? They said, oh, he's been grinding his teeth for years. He's been clenching his teeth for years. Well, I don't accept that. I accept the fact that there must be something that's missing, some airway, some. If you look at the palate, we're going to go deeper into these cases, but that connection has to come from what I talk about occlusion, and some of you have heard me this before, just the 5 basic simple rules of looking at the patient, knowing what's proper occlusion, and then from there deciding, okay, I got the bite, I got the teeth, now what's going on with the airway? What's going on with the upper respiratory? What's going on the lower respiratory? I've now screened my patient. Let's talk about his health. Where are we with his health? Right? So having that conversation, it requires us understanding what the occlusion is ideal and bite ideal. So because you have your occlusion, you'll have malocclusion. So let's talk about what I talk about with my patient, that you need to have stable holding contacts on anterior teeth. We need to have teeth that are stable, cuspid to cuspid. Not edge to edge, not crossbite, not the lower arch forward, not the upper arch anteriorly forward. So what's stable? And to some doctors, some of you say stable might be the lower arch and the anterior hitting up on the cingulum area of the opposing. Well, stable means in order for a teeth to bite down, cuspid to cuspid, I don't want to see any rotations. I don't want to see any crowding. And if that's the case, what do we do about it? Well, before we do something about it, let's understand when we're looking at these patients' proper bite. And again, I come from a background where I correct some of these using clear aligners, right? But before correcting them, I have to understand, is this patient in a proper oral health? Therefore, is there a medical necessity to start talking about this patient? So when we talk about centric relation and contacts occurring simultaneously with posterior teeth, what we're talking about is, again, another even bite. Talking about the position and contour of anterior teeth. What does that mean? Well, cuspid guidance, cuspid rise. Patient goes side to side, and you have to disclude the posterior teeth. These are the basic concepts that was taught to us back in dental school when we set denture teeth. So when you start to look at from the dental perspective and talking about immediate disclusion of the anterior teeth as you come forward, why is this important? Because if the patient's constantly grinding, and if their head now is leaning back and they're laying flat horizontal, and the mandible drops back, what's happening? exactly what we know about all of you DSP readers, all you DSP followers of, hey, mandible drops back, the tongue drops back, airway's constricted. Correct. We need to relay this so that way we start talking about where the position, where the contour from an anterior to posterior teeth, and where that lip closure path lands. These are my 5 simple points that I explain to my patients, and that becomes my immediate occlusion assessment. Once I look at the oral, I now have to connect to that medical part. I now have to talk a little bit deeper about, okay, is there a medical connection with the worn down teeth on the upper right skin that you see? Is there something going on where this patient's completely flattened? Is there something going on? Because when we look at these, we may want to fix the chip, do a crown, do a bonding. Okay, well, I don't have enough room. Let's try to figure out how we can maybe in the oral mouth we can maybe put some sort of an appliance and open the bite and do a full mouth rehab and do more crowns, right? So when you start to look at these patients, every one of these patients end up having a bit of medical connection to these bites, to these occlusion. Okay, so let's go a little deeper. Those of you who've kind of seen that last slide, you can see the wear, and I see this all the time. They say, Dr. Tai, look, there's a lot of room for this tongue, and you're talking about these patients when they sleep at night and the tongue falls back, and you know, I don't get it. What are you going to do with some of these cases? Well, understand, all of this has to have proper screening and testing. We've got to connect with a physician. We've got to connect and find out what's going on with this patient's life. And every one of these patients, I'm going to talk to you about what the physical and what I like to call comorbidities have been in connection with some of these oral manifestations that you see. So it's not just that this patient's grinding his teeth away because he's got 4 upper crowns. That's not the real reason. That is part of it. But there are additional realms where we talk about overjet, class 2 bite, lower crowding, and narrow arches. So let's talk about that medical comorbidities that's related to these occlusion that we see. So, doctors, you know that sleep disordered breathing and the fact that you have existing condition on top of additional conditions are considered medical comorbidities. Okay, hypertension. We know about that, congestive heart failure, some of those patients of ours that have some history, or even having coronary artery disease. Now, in my particular case, obesity happens to happen a lot more often. I've been trying to diet. Every time I order the salad, I tell them to hold on the steak, but I eat the steak and not the salad. So when you start to look at some of these combined physical attributes, then what we're going to look at is, are the physicians themselves, are they informing patients? Of course they are. Physicians are talking about the problems with the patients. And even the American Thoracic Society talks about oral appliances for sleep apnea. They're actually endorsing the fact that oral appliances known as mandibular advancement splints and mandibular advancement devices, they help with sleep apnea. Now here's the best part. And those of you who are paying attention, follow me on this. Because the American cardiovascular community talks about sleep apnea, talks about that oral appliances should be considered, and most appliances lead to anterior mandibular repositioning. Okay, fantastic, got it. Even there's some of them that can pull the lower jaw and thus the tongue forward, right? And if you read right here, it helps with the pharyngeal airway and adjustable devices, and anterior displacement is minimal. Okay, so we're all good. There's also a recent analysis that the American Academy of Sleep Medicine reported oral appliances. Sorry, let's see what happened here. Let me just jump back into our slide. Okay, so the American Academy of Sleep Medicine reported that oral appliances are preferred over CPAP. So we know that even the physicians are talking, in the medical community is talking about having the oral appliances as a treatment. Now, what we're going to do is show you the next slide. This is my favorite. Okay, you ready for this one? Physicians treating patients. I'm talking about the fact that ENTs, and if you look at in spring of 2015,
customized appliances that the ENTs are talking about how appliances for mild sleep apnea is an absolute, and it helps having these patients in oral appliance treatment. But I like to continue in showing you that a proper fit makes the difference. Should you be diagnosed with mild sleep apnea, an experienced ear, nose, and throat specialist should fit you for your oral appliance, while doctors who are not MDs or DOs offer the service. It is helpful to know that ear, nose, and throat specialists have the most experience in this area and can optimize the fit and function of the oral appliance. So let me see. Can we hear me over there? Because it sounds like we may not have audio. Do we have audio over there, folks?
People are posting that they can't hear you.
Oh, they can't hear me.
Go back one slide.
Go back one slide.
Okay, we hear you now.
Okay, can you hear me now?
We hear you now.
You can hear me now? Okay,
Yep,
so let me see. I don't know how much of that you heard, doctors, but let me go back to show you what I was trying to explain. So to reiterate, well, okay, so can you see the slide here where it says physicians treating patients here?
Yes.
Okay, fantastic. So physicians, and we talked about where Ear, Nose, and Throat News in spring of 2015, they talked about proper fit of an oral device should be diagnosed, and these are patients with mild sleep apnea, and this is the part that we got muted on. Maybe it was intentional by the ENT community. I love you folks. I love you folks. I get referrals from you, but it says an experienced ear, nose, and throat specialist should fit you for an oral appliance. This is going to the patients. While doctors who are not MDs or DOs offer the services, it is helpful to know that ear, nose, and throat specialists have the most, I repeat, the most experience in this area and can optimize the fit and function of oral appliances. Doctors, if you don't understand what this just said, that means that us as dentists may kind of be qualified, but an ear, nose, and throat doctor is the most experienced in this area. I thought that would be a wonderful thing for us to see, because when we're talking about connections and when we're talking about the idea of the oral appliance, should it not be us? I mean, the ADA last week, they themselves also said dentists are the only healthcare provider with the knowledge and expertise to provide an OAT. That would be us. However, you know, sometimes this is where we start to have the miscommunication. And this is where we ideal that those of you listening to pass the agenda of we're here to work together and not separately. So the physicians, and again, my awakening has been one which starts with my own family. And my awakening happened when my sons, Shaden and Ashton, were born. As a father, those of you who know exactly what that day is, I thought of the college expense right away. And the last thing I worried about was whether or not I'm going to have to worry about these kids and anything to do with Airway. It was about how healthy are they, wonderful, and can I support them for the rest of their lives? Well, my youngest one, Shaden, ended up having some issues, projectile vomiting. He had some particulars around not sleeping well. As his teeth came in, heavy grinding and bruxing. And when I talked to the pediatrician says, you know, let's take a look, let's do some testing. I said, what kind of testing? Well, it could be that he has some allergies. And sure enough, he had allergies to nuts, allergies to dairy. There was not a single thing that my son Shaden was not allergic to. And the reality was, for us, was a disturbing thought. We had to watch out what we eat and watch out where we go and constantly monitor what's around him. So I had to take some matter in my own hands as a dentist. As you know, we are doctors, we are physicians, so I did what every father may do and said, okay, I invested in a cone beam technology. I invested right away before it was all ready. We actually did some cone beam and took and understanding the airway and said, hey, doc, what do you think of this? And took this to his pediatrician. And from there, we started talking about some obstructions he's got. And maybe now, as learned as I slowly became, was looking at his myofunctional. Is this patient, who is now my son, suffering from airway issues? Is this patient, who is my son, suffering from all the comorbidities that he's been dealing with? And we slowly talked about multiple different types of treatments. Frenectomy, talking about myofunctional, and sure enough, I took matters in my own hand, but I had to connect with every physician that you can understand. It was time-consuming, but I learned so much in getting him to a point where now, as we kind of progress, Shagan, his learning disabilities, which I didn't mention to all of you, but now I will, has diminished. He got his first B yesterday. And to us, they thought he had ADD. They thought he had all kinds of different diseases that those of you who know, and there's more learned doctors that you've had on DSP than myself, talking about and what happens as you have obstructed airway. And as I go through, and he's forming, and we've become best friends with his physicians, and we've been working together in creating an agenda and having that conversation one-on-one about airway. And the question is not just about growth and health, but airway does play a big role. And we're slowly growing, and I'm growing in my dental practice, the understanding of I need to invest in some additional equipment. I had now upgraded to a community that I love in the cone beam technology with Vatec, and they've been very helpful in progressing my adventure in the world of sleep. And those of you who are now understanding that there is this oral manifestation and the medical connection, okay, where is it? How do we go from here? As you can see, my wonderful friend Mustafa on his lower cuspids and bicuspids, he's got some wear, specifically tooth number 20 and 21, heavy abfraction. He's got a bite classification of 3 on one side and somewhat of a pseudo bite classification of 3 on the other, and lower crowding. How do we use this, and how do we make this patient into a patient of knowledge, that it's not just about delivering a night guard, because he thought he's just grinding his teeth down, right? Well, we start to look at the soft tissue. We start learning, and as we go through and look at him and the proper oral appliance and proper treatment, as I talked to his physician and picked up the phone, we found out that he's had a history of cardiovascular and multiple issues, which he never once put down on his dental record. So as we go through and get him in much better health, this patient was complaining of joint pains, of teeth pain. He's had multiple restorations done, and simply just going through and walking through the steps of airway and walking through the steps of progress of medical components of getting him better. I mean, look, I use some of these cone beam technology not for the airway assessment, but rather look at his joint, look at his heart tissue, his spine, look at his cervical spine, and compare to where he is with an appliance in his mouth. And tip these patients back while they sleep horizontally. What do we get? So a lot of these procedures are helping me kind of gain better knowledge. Someone like a Claire, when Claire came in, again, her biggest complaint was not necessarily I snore or I have sleeping issues, but rather what's happening to my teeth? Why do I have sensitivity on my gum line? Again, starting, as I like to call the ING words, the chipping, right? The wearing, the grinding. So these are all happening now. They're happening today, and it's been happening. So we go from the oral manifestation, looking at the 5 points of occlusion, and she's missing a few key points. I mean, she's got teeth that are not anteriorly stable holding contacts, but rather tilted. And we start looking at the constriction on the lower arch. And then we talk to her about her medical components, and we start to dig, and she's got diabetes. Again, didn't disclose that to me either. It wasn't that important. And as we go together and we start talking about the types of treatments out there, we now, the testing and the screening and the follow-up testing and the delivery of the appliances, all of those now become part of a standard protocol, connecting the dots, connecting the physician with my office. Not just necessarily just faxing a form to them, but rather having a conversation with these patients. And guess what? You can actually, we'll talk about some of the medical reimbursements for these. You can actually get medical reimbursements for that time spent. So looking at patients where they've got rotations and crowding and spacing, I can now combine some orthodontic treatment combined with some oral appliance treatment at the same time, putting patient in a much better stable bite, much better stable occlusion, having the conversation with, in this particular case, my dental assistant and her physician, and we discovered multiple layers of helpful positions that I got to tell you, when you start to go deep with your patients, you start to understand true medicine. And yes, I can combine aligner sleep type appliances, one of which I'm very proud of being a part of, and allowing the oral movements of teeth.
And that was the most recent cover in the Opus magazine, the Orthodontic Journal. And those of you who want to know more about it, it was in the October issue. You can learn a little bit more about talking of moving teeth and placing an oral appliance, sleep appliance, at the same time. This could be done, and you have a much better stable position of teeth post-treatment. And again, looking at some of these patients, you can kind of look at the before and afters of a lot better of
treatment and combining these type of orthodontic and dental procedures at the same time. So to kind of give you a roundabout what we do best, I always love showing this video. And Peter's case was a little bit of overweight. He did lose a little bit of weight, but his problem was predominantly his wife didn't like him snoring, didn't like him having that sound at nights, and she would go in a different bedroom. And we started to go deep about it's not about snoring, it's about apneic events. Do you ever witness him not having air? And as we go through, and some of you doctors kind of slowly understand, and those of you who already know, and I'm preaching to the choir about testing, you start to see a little bit of a ray of sunshine. So I'd like to show you this video of when I delivered an oral appliance, because he was worried. Is it going to be bulky? Is it going to be thick? Is it going to work? I'm not going to wear it, doc. I just don't want something big and thick in my mouth. So watch. So we're just going to deliver the appliance. How did you do in the last week with these?
My snoring definitely improved, and I'm sleeping perfectly well.
Okay, great. So why don't you go ahead and put these on, and let's see how you do with them.
Alrighty.
Easy, huh? All right. Any jaw issues? Any pain? Okay. Tilt your head back. All right. Does that feel comfortable on your joint and jaw?
Yeah.
All right. Well, now give me your ABCs.
The hills are alive with the sound of music.
Do we start making out?
Yeah. There you go. So as you can see, his wife is actually over there as a witness, as one of our...
She's a happy woman.
I get a kick out of that, because these patients, once you start to help them, they actually truly feel happy. And in William's case, severe wear, vertical dimension broken down. We started to talk to him about, and the tori and the osteotosis, and I think just recently I saw a paper on correlation of between clinching, grinding, and osteotosis. And I think that if we can kind of talk a little bit about these bone deformities that happen during clinching and grinding, I'd love to see maybe Dr. Simmons, I call him out on this, and talk about sleep bruxism, if that creates that cellular activity in the bone, and do you get some of that bony growth because of that clinching and grinding. But regardless, in William's case, he had the tori. His chief concern was a chip on number 8, as you can see in the fracture. And we went deeper with him. Again, a diabetic, a history patient, talked about different appliances, and we treated him not just with one, but in over 5-6 year period with multiple appliances. And you know, he's been a patient of ours for now going on, I think, just a little over 5-6 years now. And talking about mandibular repositioning, which one works, you know, I don't just necessarily lock him into one appliance. I have to now pick other appliances because, again, we know that some of the byproduct of these oral appliances could be posterior open bites or TMD issues. So again, these are one which that once we take the treatment, we can't just deliver an appliance and that's it. Patient have a nice day. We're actually treating them throughout their life, as I always like to say, and they may outgrow the appliance. So looking at these patients, we do what we do best. You know, I love talking to these patients and following up with them. And here's a testimonial from one of the wives of a different patient. I thought you'd get a kick out of this one too.
Well, we're here today because my husband was snoring and nonstop for like 15 years, and I was going to kill him or divorce him, one or the other. And so he got this device from Dr. Atai, and he put it in the first night. He was so quiet. I kept looking at him. I thought he was dead. And it's wonderful because only after getting it once, not even an adjustment, he's getting the adjustment now, but before the adjustment, he's not snoring as much. And when he is, it's so soft, it doesn't wake me up. I love Dr. Atai.
I've always loved sharing this with all of you, and you know, you gotta give it to these patients. They are extremely excited, but how do I run my practice? How do I run my sleep practice? We gotta partner with the right folks in getting this done. It's not all about me, but rather my patients. But it takes some time to partner with the right people. And one of the ways I run my sleep practice is obviously I screen every patient. Every patient screened, and most importantly, it starts with the diagnosis and combined with the medical intake. We have to talk about the medical component and the dental expertise that all of you are slowly developing. And again, after the ADA, last week's kind of agenda, I feel more empowered as a dentist. I get to screen and really play my role in advising patients of maybe a prescription for home sleep study, maybe potentially an in-lab sleep study. But the reality is I now get to kind of have that conversation with my patients directly. And it's important because when you start to see these patients and you start to go forward with their treatment, now what's next? Well, my lessons learned, right? What are my lessons learned about diagnosing? I have to be able to place a formal protocol with forms and workflow. It has to be systematic. I tell you, doctors, I'm so impressed with a company like McDonald's, right? Whether you're here, Zimbabwe, or anywhere around the world, you will get the same Big Mac exactly the same way. Now, you might have heart disease after you're done with a few of those, but the reality is it's exactly the same. And in my practice, I'd like to have that protocol, forms, workflow. I need to work with board-certified MDs. These are people that not only are going to help me with the home sleep study, but rather talk a little bit about the medical conditions. And again, I don't want to assume position of taking entire workflow and the patient's health under my wing. My son, even my own son, I worked with physicians and his pediatrician and a sleep doctor. So I need to make sure that a sleep boarded certified doctor is discussing these type of, not only the dental discussion, but talk to me about what kind of primary care are we doing? Who's going to get involved? How do I pick up the phone and call the PCP? It's a lot of tasks, a lot of work, but it needs to be a protocol. And understanding that you have to now go and show this to your patient and explain it as to what it is that you're planning on helping this patient with the medical component and the dental component, the oral appliance. But how do I now put this together in my practice? Okay, so Again, it continues with the treatment planning. It continues with the a diagnosis. Once the diagnosis is given to me from the board-certified sleep physician, talking to me about what are the considerations for the treatment plan, occlusion. At what point do we do the cosmetics? Do I look at the medical comorbidities of what's going on? TMD, is a patient having jaw pain when they go forward? Do they have crowding, spacing, class 2, class 3 bite, bringing the jaw even more forward? I need to have that communication, and this is based on the experience of the dentist. And some of you dentists who are newer to it are going to be overwhelmed. Which appliance do I pick? Okay, which doctor do I call? So in my way, in the past few years, learning my lesson of the workflow, it has to be someone, and potentially I can maybe team with a third party. Is it possible that I can have a third party that has the medical, the ortho, the GP, the lab, everything all in one? Because I don't want to go one area, grab the billing, one area to get the lab, another area to get the physicians, another area to get, and every piece now my front office has to go through and try to connect the dots. It's too much. It's too much, and you end up giving up. So what I've ran into and what I've discovered and what I've been a part of is the practice growth, and bridging that medical gap is not just revenue-based, but how do I get that, I guess what I can say, the billing part, the pricing, understanding all of these components all in one box. And I always call it the software. You know, can I see it? Can you communicate with me? Patient X comes in. What do I need to do? Can you give me a treatment plan? And this is ideal if it's already done. I come from the Invisalign world. I come from a ClinCheck world. And those of you doctors who know what that means, we're not buying a attachment. We're not buying a ClinCheck and then accepting it and then paying a monthly service and then ordering the align. It's all in one, and that's what I really like in having in my sleep practice. So that bridging of the medical community and gap isn't just necessarily knowledge. You can take multiple courses, but at the end of the day, how do I get my patients into treatment and get paid for it, A, and be able to have that communication with the medical component, so then I'm continuing this next few years or the lifetime of the patient with treatment and therapy. Well, again, looking at communities of multiple different softwares, multiple different products, I don't want to just buy separate ones. I want to get one. And that's what I've been doing. I've been partnering with a company that I'll disclose to you in just a minute, but I don't want to do the billing myself. I don't want to worry about my front office calling and trying to get 40 minutes of verifications and am I ready to do this, am I not? What's the code? Can you give me the code, taking a billing code? I don't want them taking percentage of my money. I want to make sure that I'm able to have all of it in one box. And so I've partnered with a company called Sleep ArchiTx, as you see, who's helping with this webinar. And as you can see, the multiple checks that's been received from $6,000 to my cone beam technology of $600 to my other appliance of $7,000. These are just for treatments of the entire system of the oral health, and as well as I can now combine some orthodontic treatment. I can have multiple assets now added to my practice without disturbing my front office, without disturbing the actual screening, testing, billing, and making sure that a reimbursement is happening, and that communication with the patient of software, the patient communication of having myself be able to show a patient of what the treatment plans are, and having experts help me do this, orthodontists, sleep physicians, and even lab technicians, all to my disposal in one box. And that's what this company, Sleep ArchiTx, has helped, and I've been part of their team, and I'm very excited to announce that in the past 2 years, that's what I've been doing, and trying to bridge that medical and dental connection. So those of you who, I know some of you may have some questions, and sometimes I heard that the volume had dropped down and some of the slides were not quite running through. If you'd like, please go ahead and you can go ahead and I'll take your questions, and I'll be more than happy to answer them now if you have any questions.
Dr. Ty, thank you for that presentation. That was really good to see all those different parts coming together for that. We do have some questions from the audience here. I have a few to ask you. One thing you actually start from the end here just a little bit. You talked about getting paid from private insurance. You didn't mention Medicare on there. And the question from the audience, do they need to be in network for these kind of things? And can you talk a little bit about the way that Sleep ArchiTx can help with insurance and coverage like that?
Sure. Well, in my particular office, I'm not involved with any kind of Medicare or and to be honest with you, I'll tell you why. Okay, I'll tell you exactly why. The reimbursement is very low for my area. We're talking, it pretty much covers the cost of the actual fabrication of the appliance. And I have not gone that route. But Sleep ArchiTx can help and has the option of helping doctors enroll. I know that they've done that in the past. I've always been one that says, look, it depends on your area of practice and depends on what you're looking to do. In Laguna Hills, California, I've got at a location where I'm able to kind of use the PPO coverage as more beneficial and cash out of pocket to patients. And again, in some areas and some localities, doctors want to be involved. And you know, for me, 2 or 3 or 4 appliances a day is great. I do anywhere between 4 or 5, sometimes 6 a month, and at other times more or less. And it warrants that $6,000 to $7,000 kind of treatment planning that is really part of it. You've got the cone beam, you've got the actual face-to-face that you have with patients. There's an entire year potentially that you're talking to the treatment for these patients. It's not about just the appliance, and that's the one issue that I have with you know, enrolling with those types of programs.
Okay. Can you say a little bit more about, you mentioned symptoms, TMD symptoms following appliance therapy. I know there's a lot to that, but can you say a little bit more, how common is that for you, and how do you prevent that? What do you do to foresee that, those kind of things?
Sure. So, for instance, in William Dameron's case, he's actually undergoing multiple. Let me get his case real quick. He was undergoing multiple types of treatments, and what ended up happening with him, if you look at from the initial appliance that was given to him, where we were more edge to edge, maybe about 6 millimeters forward, the appliance and the efficacy, as we did the sleep test, he needed to bring the mandibular jaw more forward. Obviously, the CPAP was an option that was given to him. He didn't want to follow up with that. He didn't want the CPAP. He travels a lot, and for him, he wanted to fix that front tooth as well. So as we go forward and we kind of fix that tooth number 8, and if you look at the before where there's a chip on 8 and kind of where he was in his vertical completely collapsed, as you bring the jaw forward, you can potentially develop some of these pain on the joint. And for him, he started to have not necessarily pain, but the fact that he's snoring again. And he's waking up a little bit tired. So if you look at the next appliance, he's coming out, I've come out almost 9 millimeters on the lower mandibular arch, and that's where it showed on his home sleep testing, and then we ended up doing it in lab, as being most effective. So for him, you know, we wanted to make sure that we kind of create this continuous follow-up with him. I follow every 3, 6, 9 months, and this is kind of a follow-up that I do on all my patients, checking the occlusion, checking the vertical, looking to see if the posterior is getting light or not, and having that conversation. So my protocol is mostly in making sure that posterior teeth, first molar to bicuspid, don't get any kind of space between them, if that makes sense. And at that point, if it is, I you know, that'll be our next maybe webinar where I actually have treated some of my own patients that got a little bit posterior open bite, and we either whether do clear aligners or kind of use a different appliance, and having to bring their bite and use you know, you can't just use the same appliance forever on these patients. That's what I've discovered. I've discovered you have to kind of change these appliances. And again, with Sleep ArchiTx, with their orthodontic help, they have orthodontic specialists that have helped in getting advice of, okay, this is the appliance, good for now, if this is happening, kind of switch appliances, and they help me with that. So hope that explains it.
Does your cone beam help you with that kind of thing? And another question came in: Do the cone beams, are they necessary for doing oral appliance therapy for sleep apnea, or what if I don't have a cone beam? Should I get one from my local lab, or how does that work?
Great question. So when I first started, the idea of cone beam was I can buy a Ferrari. Why am I buying this machine? And of course, with my son and looking at it, saying, okay, I've got to be able to visualize this, and Panorex just isn't working out as well for me. I don't believe having a cone beam is necessary. I believe that having a cone beam allows you to look at some of those craniofacial areas. For instance, if you remember, we talked about the cranium, and we talked about the face, and looking at the mandibular areas. To me, that gives me a good assessment of kind of evaluating the patients before and after. And if I start to see too much of that opening in between the condyle area, and some of you doctors know what I'm talking about in looking at these, then at that point I use that as an assessment. Is it one for airway? Am I using it for airway to see where you see these images where it looks red, and is it, and the other images looks like that the airway opened? Well, by bringing the jaw forward, as you can see in this second photo on Mustafa's case, his airway's opened. What I look at is looking at these hard tissue. So the cone beam really helps me in looking at potential, assessment. Now, do you have to buy one? No. I used to use a mobile one. I used a mobile van. The guy would show up to the patient's work or office, and I think it was a couple $100 he would charge my patients, or at that time I don't think he was billing insurance. I don't remember. And that was it. I mean, there's also imaging centers, imaging lab that charge less than a couple $100. So do you need to have one? The answer is no. Do I get one? Well, I got two. I bought one and then upgraded. Yeah, I bought one. I had an iCat one, and then I upgraded to the Valtech. So I like, you start to see some distortion. You kind of get picky, doc. You know what happens? You get that first machine, and then there's other ones, and you're like, this other one looks a little better. So then you kind of upgrade, and that's kind of what I did. Okay. So for me, I like it. I think it's a very helpful benefit to my practice. And I get to talk to my patients right away. I get to show them. I get to show them right away of their images as to what's going on. And again, I think that finishing the idea of cone beam, a lot of us worry about radiation, but you've got to talk about microsieverts. We've got to talk about what is the amount of radiation of a cone beam on a 5-second, 8-second, 3-second, 15-second, and you start to look at that versus a full mouth X-ray. And when you start to educate yourself on cone beam technology, you realize, wait a minute, a full mouth X-ray could potentially have a little bit more than me doing a short scan on my patients to evaluate. So we need to educate ourselves a little deeper on the cone beam technology, but I appreciate the fact that doctors, if you're planning on it, you don't have to buy it right away. There's multiple other avenues that you can exercise for visualizing this.
I love my iCat too, so same kind of thing. So say more about education also, because man, there's a ton of sleep courses out there. Both you and I are out there lecturing, doing sleep courses. There's a lot of other choices out there. And so where's the best place for these dentists that are intrigued by what you had to say here and other things? And where's the best place for them to learn about all this?
DSP, of course, right? Well, I mean, that's what we're doing, right?
Thank you.
Well, I got to tell you, and if you look at this slide deck, I think where I've got educated and where I've kind of learned the most of my knowledge is practicing it, right? You can sit through courses. And in my world, there's a program that I've put together for the Invisalign doctors called Elevate. Okay, so they sit through, they get a little bit of clear aligner treatment, they get a little bit of occlusion, a little bit of moving of teeth, minor tooth movements, and then sleep. And then you go through and say, okay, then what? Well, look, when you partner with the right company and they're educating you in the entire system and process, then why would I need to waste my time out of the office? Bring it into my office. Look, I travel just like you do in lecturing, but I love my Monday, Tuesdays, and Wednesdays. I get to see my patients hands-on. I mean, look, I was in scrubs today. I did 2 comp reps, 1 filling, and I delivered 3 oral appliances.
Hey.
And the reality is, I love that, right? But going out and trying to book a hotel and do all that stuff, and then there's course fees, and okay, now you got all this education, then what? What are you going to do with it? You can be as educated as you want. You can learn how to do the best ground prep. If you don't pick up the drill and drill that tooth, you ain't gone nowhere. So in my world, partnering with the right company, having them get you trained, get started, then start taking some courses. Let's start to look and see, okay, here's the entire box that you're giving me. Let me play in it. Now I pick, just like minor tooth movements, right? Let me start with 2 millimeters of crowding. Let me start with 3 millimeters of crowding, and you start to educate. Now you're doing class 2s, right? Rubber band techniques. So my world is one which is partnership is most important, because I don't believe that these companies are vendors, but rather true partners in my practice.
And so that's what you find in sleep architects. That's why you got involved with them, is because they can carry dentists from A to Z on all that, right?
Absolutely. Absolutely.
But I wanted to make sure that the attendees heard that. Well, what are the benefits of sleep architects? I mean, you got some physicians, people that are amazing in our profession are part of that, because that's what the people that go to sleep architects can get out of that. Not just you, but also physicians and orthodontists
Absolutely.
and other people, right?
Absolutely.
Yeah.
Yeah, and that's the beauty of it. I mean, the orthodontist that I collaborate with as part of the sleep architects workflow, as part of the actual software, you know, that's how you learn. I mean, it's a one-on-one conversation. I pick up the phone, even as a practitioner. And again, I've been involved with a company as a KOL and part of the company, and the reality is, because I'm able to have that communication with medical physicians, a true-hearted conversation about, okay, what do I need to do with this patient? That's the learning process. To me, that is learning, and I'm making money from it.
Great. Sounds fantastic. Well, Dr. Tai, thank you for your time tonight. We're out of time for this, and if you had questions you've sent in, I'm sorry we didn't get to all of those. Please just keep sending the questions in, and we will get back to you with email answers if we can. And anyway, thank you again for your time, and I hope everybody enjoyed this presentation from MedMark Media and Dental Sleep Practice Magazine. Have a good evening.
Bye. Bye-bye.
Bye.
Oh, that's it.